to our guest speaker. I think he is online. Welcome, Dr. Chronopaulus. Dr. Chronopaulus will be talking to us about the changing treatment paradigms with durability and drying. You see, this was one comment I made in the beginning only, these two Ds about, because patients are concerned today about repeated visits and they actually sometimes get fed up of repeated coming for injection and repeated consultation, repeated OCT examination. So what they want is a long-term relief. And we know that, new generation anti-VEGF agents, brodocimab and other agents also, they are today working for, more than 2-3 months also. We talk of Q16, Q12 very commonly. So let's hear Dr. Chronopaulus from Germany. Welcome, Dr. Chronopaulus.
Yes, good morning. Many thanks for having me as a guest on your wonderful meeting. I will be talking today about the changing treatment paradigm with durability and drying in AMD and DME. This is the necessary disclaimer. Now, we know that the subretinal fluid, the fluid in general, is very important in the treatment of NAMD and DME. And most of our treatments and protocols today, they are based on our decisions, and they are based on the fluid and OCT, unless dictated otherwise by the health insurance. And we know that the longer that the fluid persists and the longer we have fluctuations, this is translated in less vision and worse results for the patient. So we need an agent that dries faster and better the retina in both diseases. When I'm saying that, we know all the percentages. There is a 70% of patients, this is true, who are untreated in the first year, with 50% of patients receiving less injections in a year. And in total, if this go on, then we have a 60% of non-adherence of the patients this develop in total, and then you can understand this translates into worse results. Why I'm saying this and why is compliance an issue? This is the same for NAMD and DME. You see how busy the patients are coming back from consultations, receiving treatments. It has been estimated and calculated that in average, a patient is about 9 hours rest after consultation, in total 12 hours for the treatment, including the persons or the caregivers that are escorting the patients. So as far as AMD is concerned, we know that on the left-hand side, we have the majority of the patients. The majority of the patients, they receive less than 3 injections, or at least equal to 3 injections in a year. This is for the NAMD. And the question that arises, just by seeing the RCTs in the real world, you can see the discrepancy between the gain, the functional gain on the left-hand side and the right-hand side. How is it possible that we make it shift to the left as far as the AMD is concerned? And the same applies to diabetes. We know from the big registration trials for ranibizumab and aflibercept that we had a significant percentage of patients that were not completely dry. So we had about 26% in OCT and 74% in NFLA with ranibizumab, and about 32% with vidinvista. But even in the independent trials, the protocol I, for instance, or the protocol T, they have also showed exactly the same results, that we have a significant percentage of patients that are not completely dry during the treatment in the first year. And this is how the real life looks like. We have about 50% of patients, if you look on the left-hand side of the graph, that received equal or less than 3 injections in a year for DME. And the same question arises also here: how we can make those results from the real world correspond to the results that we see from the registration trials with a good vision gain. Now let's see what brodocimab is doing in AMD. We all know the Hogan-Harriet trial, which was the registration trial for NAMD, and the comparator in this trial was the aflibercept. We know that function-wise, there was a non-inferiority for the drug, but the drug, brodocimab, has shown robust effects in drying the retina. You can see the red numbers. We have much less patients having intraretinal fluid and subretinal fluid and sustaining that. These are the relevant graphs. You can see the gray line. These are both trials, the Hogan-Harriet trial, and you can see the difference, which is more pronounced in the higher trial. in how fast the drug is working and drying the retina. And not only that, you can see the graph how fast the effect is reaching its ceiling in brolucizumab group compared to the aflibercept. Of course, all this is translated in number of injections. You can see the graph on the top left side. You can see 2.4 injections to reach the 60th percentile. And you can see on the right side, the 76th percentile with 5.4 injections. So we're talking about almost a half for the effect of brolucizumab in terms of treatment burden. So less injections indeed. And if we look at the post-hoc analysis data, you see three columns. The darker ones that represent the brolucizumab, and the lighter ones represent the aflibercept, and the cumulative percentages on the right-hand side. You see that more patients reach dryness in weeks 96, which is basically 1 year. So brolucizumab achieves a faster and sustainable dryness in AMD compared to aflibercept. We make a small conclusion in between for AMD that more patients under brolucizumab achieve sustained dryness, and the time to first absence of IRF and SRF was significantly shorter in patients treated with brolucizumab. And if we take it up to a year, we see that 50% approximately of patients treated with the brolucizumab, they have a dry retina, a dry macula. Now, what's happening in diabetes? Again, we see the same trend that letter-wise, function-wise, there was non-inferiority of the drug, but the patients treated with brolucizumab, they had more patients with less intraretinal fluid and less subretinal fluid in the retina, which is actually exactly what we're seeing also in the NAMD. You see the relevant graphs over here, and it's more pronounced in the Kessler and Kite studies, which were the registration trials for the brolucizumab in DME. And you see that the obvious difference in how fast brolucizumab is drying the macula. And not only that, we have also functional results, as I showed before, that more patients are having a dry retina compared to the comparator, which was aflibercept. And if you look at the top of the graph, you see the obvious effect. We receive better results, better drying with less injections. Take one example. The left-hand side, you see week 100, we need 11 injections of brolucizumab and 15 injections of aflibercept. And of course, there are more patients treated with brolucizumab that achieve at the end of the 100th week, which is 2 years, they achieve a dry retina. And obviously with less injections. You look at the right-hand side, the Kite trial, we have at the end 15 injections with aflibercept and 10 injections with brolucizumab. Now, if we take this under consideration, is it possible to stop a treatment? This hasn't been indeed investigated a lot or at all in the current trials, but indeed it's positive. Indeed, it's possible. We take one. There is only one trial that has looked actually in this question, which comes from Switzerland, and these were patients treated. These were patients from the registration trials that were observed after the end of the trial, which means after 2 years. And you can see the amazing results. We start with the baseline in both cases with the retinal fluid. After 2 years, the retina is dry, the macula is dry. And without drugs, between 2 years and 5 years, the retina is dry. So it is actually possible to even stop the patients from the drug. Now, as far as the registration trials are concerned, now let's take a look about the real-world experience. We have, this was a patient, 81 years old, came into the consultation. You see the angiography on the top, and you see the OCT on the right-hand side on the bottom. There is an obvious PED and subretinal fluid. The patient received 3 brolucizumab injections, and on the 4th month, came back for a follow-up. Everything is dry. The PED is almost completely gone. There is a significant increase in vision from 0.1 to 0.4. This prompted us to do a study and analyze all the patients that were recalcitrant to other drugs. How would they react to the newer drug. And all of those patients, they also had a PED. Now, we had 20 eyes treated in this study, which was published 2024, submitted 2023. And all of the patients, they had a heavy history before them. They had about 10 injections, and the patients were not happy. So what happened is that we put them on brolucizumab, and you can see on the three columns, the first one is indication of anti-VEGF when everything started. Then in the middle, when we indicated the brolucizumab, and at the end, how it ended at the follow-up, you see a robust gain of vision, and on the right-hand side, you see a robust gain in tissue. So the drug is really working. It is improving the retina significantly. And you can see an example here of a patient with a very pronounced PED with much of subretinal fluid. Left-hand side is when everything started. In the middle is when we changed to brolucizumab, and at the end, how good the PED is deflating and the subretinal fluid is really disappearing. And if you're thinking about PED, this is a space under the retina, which has a certain volume and area. We also calculated that, and there is about a 60% reduction in all this. Now, what about DME? Is it the same? Take a look at this patient. This was a female patient, multimorbid with type 2 diabetes and insulin, and all the risk factors not to respond well. Renal insufficiency, sleep apnea, hyperlipidemia, nicotine addiction, and things like that. So she came in the consultation. Both sides had a very nice cystoid macular edema. Vision was 0.3. Injected per label, 5 injections every 6 weeks. Came back week 24 with a vision of 0.8 and disappearance of edema in both eyes. This patient is straight also from the consultation. I saw him 2 months ago. This is the state of the retina on the upper side. Before every treatment, this was a treatment-naive patient. Injected 1 brolucizumab injection. He's still in the treatment. I just took the images to show what's happening just only with 1 injection, how the retina is smoothing down and deflattening. This is another patient, exactly the same. Saw him 2 months ago in the same consultation. Just 1 injection of brolucizumab, and the whole fluid is disappearing. This prompted us also to do a similar kind of study in real world. We analyzed primary and switched DME patients. We had in total 32 eyes in this analysis, which has been submitted but hasn't been published yet, has been submitted. And the patients that were treated before, they had ranibizumab in the history, they had aflibercept and dexamethasone in blood. So you can see again on the upper left side, the functional result. There's a robust gain in all groups and of vision, and a robust gain of tissue on the upper right panel. But the most important thing that comes out of the study is that for the first time, I'm not aware of any other study that's not showed this before, there is return and improvement of visual density in the retina and perfusion density, which means that the patients before they were monitored with the CTA before the treatment and after the treatment, we see an improvement in the retina, we see an improvement in the circularity of the fovea, and we see an improvement in total of the capillaries and the perfusion. You can see here the numbers in the left-hand side. You see the numbers before the injection. In the middle, you see the density of the capillaries after the injection. You see the difference, which is going up, and you see the increased circularity of the fovea after the loading dose. Now, of course, if we're talking about the aflibercept of the brolucizumab drug, we all know the dramatic launch of the drug back in 2019, 2020, and there are many colleagues that are questioning and are still reluctant because they think that the drug will increase the probability of having an IOI. Now, if we look carefully at the data, it would take the first publication of those cases. We had 10 surgeons in the United States with 12 patients, and they all have been treated before with 2 to 80 injections, and they showed an IOI 30 days after the treatment started. But if we look exactly the numbers, we see that there were from all the cohort, there were 3.3% of vasculitis and 2.1% of RVO. And of those patients, we had less than 1% of vision loss with associated risk of 0.6. Now, interestingly, also the patients that had IOI then continued treatment compared to the other groups. There was a drop rate which was the same in both groups, actually. And if we take studies have been conducted later on, for instance, the study from the group of Marconi, for instance, they reported 0.4% of retinal vascular occlusion as an IOI. A study of Marcos Arbit, for instance, reports an IOI percent of 1.2 and an arterial occlusion of 0.2% with no retinal vasculitis or panuveitis. And there is also a very interesting study from India, the VRSI study, which reported an incidence of IOI of 0.8%. As a take-home message for my talk, brolucizumab is a very effective and stabilizing drug for NAMD and DME. This is the only drug with the fastest fluid resolution in the market, and faster. This means faster improvement, function improvement, and faster reduction in treatment burden, as we have seen also from the registration trials. But I'm seeing also in my practice that the patients, they need lesser injections and they have better results, and it's also possible to wean them off the treatment. Thank you very much.
Thank you, Dr. Chronopaulus, for confirming what we also believe that this is one drug which works very, very nicely as far as resolution is concerned. I believe that if there is a faster resolution and more resolution, then it should also translate into more visual recovery also. Although RCTs show that this is non-inferior, but the fluid, if it goes away faster and for a long time also, then ultimately these patients should do better in terms of vision also.
Yes, that's exactly correct. There was a discussion about 10 years ago that I happened to hear in the United States. And I think it must have been an ARVO meeting where they were arguing whether you can leave fluid in AMD compared to DME. And at that point, they said, well, yes, for the DME you can leave a little bit of fluid, but not for the AMD. And now we have reached another conclusion: the retina has to be dry, and the more fluid you have and the more fluctuations you have, the less probability that the patient is going to recover as much as possible in the long run. Having said this, it's obvious that and from the studies that I've shown you in this talk, it's obvious that there is an obvious issue with the number of injections given to the patients every month and the number of injections that they need every year. As all things started with ranibizumab, we're seeing a horizon of about 11 injections a year. This has been brought down now to 7 or 8 injections, which translates automatically to less treatment burden, which is more friendly for the patient, and they do reach better results.
Do you believe in starting treatment with brolucizumab or only patients who are resistant or recalcitrant?
That's a very nice question. Very much, many thanks for this question. We had a dramatic launch of the drug, as you know, 2019, 2020. And as with every drug, we're a little bit reluctant at the beginning. And we tend to indicate the new drug in patients that do not respond with drugs that we actually know quite well how to handle. Now, this is how I started my treatment with the drug. Currently, and having seen all those results in my consultation, I start right away with brolucizumab.
Yeah, I think with passage of time, the confidence level is increasing. I just heard a talk by another speaker in the morning session. His first agent of choice today, considering the effectivity, drying, as well as the cost also because the frequency of visits go down, is today brolucizumab. Ajay, your take?
Yeah, so nice presentation. I have one question. You know, there have been fluid studies which have shown that a minimal amount of fluid might actually be protective. But Hawk and Harrier particularly showed that even little bit fluid actually in the long run can be counterproductive to the visual recovery. And maybe because of the drugs which were used in the fluid studies were not as potent as brolucizumab and therefore were not able to dry the macula as much as what brolucizumab does. But there is a difference of opinion. Fluid study says if we leave a little bit of fluid, it may be better versus Hawk and Harrier saying that you leave this fluid and it will actually not result in better visual acuity. What is your take on that?
Yes, this is also a very interesting and nice question. I can also answer. There have been other studies that have shown that the fluid matters. So if you leave fluid, then at the end, the long run, you will have less vision. I think, from my experience so far, having fluid is for me, from my experience so far, for AMD, fluid is not a good parameter if you leave fluid. From my opinion, you can wean off patients with DME just with a little bit of fluid, which have reached a very good vision, 0.8, 1. We have seen patients with 1.2 having a little bit of fluid. You don't want to do over treatment, but in overall, if I start somebody and I see those robust results, I tend to try to dry out the retina.
Dr. Chronopaulus, I firmly believe that no fluid is good. No fluid is good. You see, persistence of a fluid means defeat of the drug. If the same fluid can be dried by brolucizumab or Pagenax, so what is the big deal about it? I do not believe this concept that some fluid is good for retina and some fluid is bad. I agree IRF is the worst kind of fluid, but that does not mean you allow SRF to persist. Because if there is a patient who has SRF and if I can get him dry with one injection of brolucizumab, then why not?
Yes. Fluid is, I see it exactly the same way you do it. I feel disturbed about seeing fluid in the retina. So if I have the option to do it, yes. But some patients, they do get fluid. In those cases, of course, the drug will work up to a certain extent. You cannot dry everybody, all patients with the same drug. This is true because every patient is different than the other, and you have to take into consideration more other parameters. You have also a magnificent laser in the clinic that you can also use. The focal laser, at least in diabetic macular edema, is still a valid option that you can use.
I agree, laser can be used, so many other things can be used, but persistence of fluid, if it can be dried by another agent, I think it's the defeat of the previous molecule. I think we'll go on because we have 2 more lectures and we will request you to please hang on, and because we may have some good discussion coming out of the next 2 presentations. So I'll call upon Dr. Sen Gupta to tell us about breaking the barriers.
And we want you to stay on online so that any questions come up for you, we'll request that they are asked for you.